So our next speaker is Dr. Mara Antonoff, Associate Professor at MD Anderson. She's also the Program Director of Education and Thoracic and Cardiovascular Surgery. She's making her way to the stage. Take it away, Mara.
Thank you very much for the privilege of being here, and I want to thank you for the opportunity to follow so many outstanding evidence-based talks with my very data-sparse pontifications to answer this question. When metastases disappear, is stage meaningless in the face of biologically tailored systemic therapy? And I would argue that Dr. McGuire already answered this question for us by telling us that the future of staging is molecular. But I'll take you through some of my thoughts in addressing this question. So again, when metastases disappear, does stage even matter? So let's take us back a little bit. I know we heard all about the history of staging, but why do we even stage patients in the first place? What's the purpose? It's to provide a prognosis. That's why we have a stage. And what is the system that we use? Is TNM at this point until we add the B? And what's the nature of the data? It's all anatomic, 100% anatomic. So, we've always looked at tumor in terms of its size and location, whether or not the nodes are involved, and whether they're hilar or mediastinal or more distant, and whether or not they're metastases. And then, of course, we know in more recent staging, we've looked at how many N2 and where are the sites of metastases and what types of metastases are they. But again, don't forget, all of these data, all of these points, they're all anatomic. None of the advanced biologic aspects that were all introduced by the other speakers earlier today. So are the anatomic traits always accurate predictors? Of course the answer is no. And are the anatomic traits the only predictors? Obviously no, we've already discussed this today. So are anatomic traits even the most important predictors? I'm gonna argue no, absolutely not. It's what we've always used, but they're probably not the most important predictors, and they're probably not the best way for us to predict biology. We've already talked a lot about the history of TNM staging today, but just remember, as was published more than 20 years ago, the objectives of TNM classification are to aid the clinician in the planning of treatment, to give indication of prognosis, and to assist in the evaluation of the results of treatment. And even was recognized more than 2 decades ago that the most important challenge facing TNM is how to interface with the great numbers of non-anatomic prognostic factors that exist. So looking at TNM milestones, is anatomy obsolete? Looking back at the history, we talked a little bit today about the history of TNM staging for lung cancer, but for all malignancies overall, a lot of these dogma that we use go back to the 40s. And certainly as we continue to update things and try to make them more modern, more updated, are we continuing to just try to have reiterations of something that was built off of the wrong approximation in the first place? Should we even be using anatomy? Lung cancer is always a little bit behind the other cancers, so let's look at colorectal cancer and some insights from more than 20 years ago. Even back in the early 2000s, looking at colorectal cancer, the proven factors for prognosis were anatomic extent, but also grade and venous invasion and the surgeon doing the operation, with a bunch of additional probable factors related to outcomes for colorectal cancer. But then a ton of other possible factors they were looking at, most of these being biologically based blood markers that they were looking at a very, very long time ago. Here we are 20 years later still wondering if anatomy is the way that we should be looking toward outcomes for lung cancer. Anatomic staging clearly has its limits. Other methods should be explored to help express overall prognosis without losing the vital anatomic content of TNM. And again, this is all from a paper from over 20 years ago. We didn't know much about AI back then, but right now, we're all using ChatGPT to figure out what we should do to entertain ourselves while we're in Montreal and have a few extra hours. And here we are, decades ago, looking at hearing ideas about artificial neural networks that could offer the potential of integrating numerous and diverse prognostic factors, not just anatomy. So we've all looked at the staging multiple times today, not to mention millions of times in our lives already, but right now in this moment we're talking about stage 4 disease, and of course this is an early stage summit, and I'm here to explain to you why I really truly believe that in patients who have had an appropriate biologic response, that what we have always called stage 4 disease may actually be more similar to early stage disease. So what we're talking about again are patients with M1 disease, and I think you're all very much familiar with what stage 4 disease is and all the different ways that we classify it here in 2025. Let's take a step back though and think about stage 4 lung cancer and what was the standard of care in the past. 10 years ago for stage 4 disease, even though there were all these different things that we aren't exactly doing anymore necessarily for stage 3AN2 disease or early stage 1 or stage 3B. A lot of these things have changed, but stage 4, really 10 years ago, chemo, that's what we did. We tried to prolong survival and to give people a little bit more quality of life with chemotherapy. So for the longest time, treatment of lung cancer has really been stage dependent, with surgery having an important role in stage 1 disease and a combination of multiple modalities of therapy for stage 2 and 3, and systemic therapy really being the mainstay for stage 4. But what were the outcomes when we were treating patients under that paradigm? Looking at these data back from when that's how patients were treated, if you look at median survival, these are in months, and I want you to remember these numbers when we talk about stage 4 disease in a few minutes, that for the best case scenario, this is a female greater than 50 with a good performance status. Best case, 7.4 months was the median survival. Worst case in this paper, again from the early 90s, is that patients with poor performance status, under 45 years old, median survival 2.5 months. And the largest growing group that we have right now, the patients I see the most frequently in my own clinical practice, patients on whom I'm operating, who have great performance status, often women who are fairly young in age, the median overall survival at that time, when all that people were getting was chemotherapy, was 6.6 months. So I would say that's abysmal, and so clearly we're doing something wrong by looking only at anatomic factors, if that's how we treated patients and those are the outcomes we saw, and we're able to do better now. Just compare those numbers I just gave you to these results, which show multi-center survival outcomes of patients with stage 4 lung cancer in recent years. This is a combined cohort from University of Zurich and MD Anderson Cancer Center, patients with stage 4 disease who underwent surgical resection as local consolidative therapy. Many of these patients with polymetastatic disease, some of them with oligometastatic disease. Median overall survival in this group is 77.9 months. That sounds a lot better than 2.5 months or even 6.6 months. So what is different? It's that we're not just looking at these patients in terms of what is their anatomic stage of disease, but we're looking at their biology and making decisions about how we can best treat patients based on biologic factors, and recognizing again that biology is king at the end of the day. So I'm very proud of these results, what we've been able to accomplish surgically in patients with stage 4 disease. But again, in stage 4, the right definition, is that even how they should be categorized? Should we be referring to these patients as patients with stage 4 disease, or should we be responding to them with biologically responsive disease, categorizing them as patients who responded well to the treatment which they were given? Are we thinking about stage and stage 4 all wrong? Are the dogma of stage 4 in surgery and in terms of all of our therapeutic options really more like early stage than locally advanced disease or like really aggressive disease? Even as a surgeon, we think about in stage 1, surgery achieves local control, but when we give adjuvant therapy, when we give other systemic therapies, we're trying to manage their biology. Stage 2 and 3, perhaps we still are a little bit more aggressive in terms of understanding the need for all of the integration of these different modalities to manage local disease, regional disease, systemic disease that's potentially already escaped or is on its way there. But honestly, when we think about stage 4 and a lot of the local aspects, we've found that surgery achieves local control. And again, we're back to just managing the biology of the disease systemically, like we do for stage 1. So maybe stage 4 disease, some cohorts of it, some subsets, really do belong being discussed at Elixir. Maybe this is an early stage problem. Should we be measuring response rather than the stage of presentation? Stage 4 certainly has its own range of outcomes. We recognize that for some individuals, there's a potential opportunity for more aggressive local therapy. A lot of people thought, well, oligometastatic state is one of a limited disease burden and distinct tumor biology. We know there's a spectrum of associated outcomes. So some people like to think about it as though oligometastatic disease is really kind of the more favorable. But should we even be thinking about it like that? Should it be more, what's the response to therapy? Is that really the answer? I do think that within the realm of stage 4 disease, oligometastatic has been leading the way with the most evidence, creating a pathway for more extensive disease and more aggressive disease to be considered for resection. But again, extensive disease, aggressive disease, these are words that I'm using based on us always using this anatomic definition of stage. So maybe somebody who's polymetastatic and has a phenomenal response to a targeted therapy shouldn't be thought of as more aggressive or someone having more extensive disease, but rather someone who has biologically responsive disease. Should all of our staging really be more about how people respond to the therapeutic options that we have available rather than thinking about how much burden of disease or what their volume was at the time that they presented? I do think that oligometastatic is a little bit different than both early stage and than polymetastatic when we think about criteria for surgery. Certainly they're more stringent for oligometastatic disease, but less stringent than for polymetastatic disease. Intraoperatively, for patients with oligometastatic disease, we really do try very hard to get an R0 resection, more so than we do for polymetastatic disease, but we know that many of the dogma for surgery in early stage disease don't really apply to stage 4 in terms of lymphadenectomy and need for anatomic resection. Many of the things we're trying to do to prevent kind of the horse from getting out of the barn have already happened. And then in terms of management of other sites of metastases, we know that for oligometastatic, that comprehensive LCT really matters. It may be less applicable to polymetastatic disease. What I was saying about extent of resection, when we have looked at a single center review of patients with stage 4 disease who underwent primary tumor resection, we found that sublobar resection resulted in comparable survival outcomes to more extensive resection, and this was corroborated by a multi-center experience. Likewise, looking at lymphadenectomy, we found in a large multi-center review of patients who underwent surgery for stage 4 disease as local consolidative therapy that local regional recurrence is similar for complete versus incomplete lymphadenectomy, and that overall survival between the two groups is also very similar. So some of these dogma that we've applied to early stage disease don't necessarily apply in stage 4, but again, I don't know if the staging that we're using, all anatomic, is even what we should be doing going forward in the future. When we look at long-term outcomes of resected oligometastatic disease, here I'm showing you time in years down at the bottom. You see years 1 through 5. These are patients who, after a median follow-up of 95 months, had a median overall survival of 52 months. This is substantially better than those numbers I was showing you earlier, 2.5 months, 6.6 months for patients treated with chemotherapy alone. And so it's not just that we're operating on people, but it's that we're operating on the right people, and we're learning to measure patients' likelihood of having a prolonged favorable outcome by other factors other than just their anatomic extent of disease, but rather their response to therapy and using more effective therapies and finding a way to use those therapies on the right patients and get them to the right strategies. When we talk about surgery in stage 4 disease, there's a lot of questions. Which patients, how many metastases can they have, what's the best timing, and how do we address all these intraoperative nuances that I brought up? We do have some recent guidelines that we published earlier this year, and just to summarize what this chart shows for you, strong recommendations are made to support lung resection as local therapy in oligometastatic disease. Moderate recommendations include resection in well-selected patients with polymetastatic disease and even oligoprogressive disease, and there is inadequate data to support how much lung should be resected, whether lymph nodes should be extensively resected or more limited, and the exact operative approach. But the key point here is that all patients with oligometastatic lung cancer should undergo multidisciplinary evaluation, including surgical consultation, so we can talk about these things, not just an anatomic label of stage 4 disease, but really what systemic therapeutic options are available, what is their response to those therapeutic options, and whether we should start thinking about how aggressive their disease is based on their response to therapy. When all those other sites of metastases disappear, are they really more like an early stage patient? I think what I'm trying to tell you is that I believe that stage is a surrogate. It's an artificial construct by which we are attempting to capture the real players. What really matters? Predetermined biology and our ability to interfere with predetermined biology. And I think it's those two things. And so we look a lot at stage because we believe that it's telling us the biology. The reality is that stage is telling us how aggressive the tumor is and or how long it's been there. But really, the biology can include more than just that stage, and looking at the stage, the way that we measure it right now anatomically, it doesn't tell us our ability to interfere with that predetermined biology. That second piece is missing. So I think it's been great for a long time. We've had a good run of using anatomy to tell us the predetermined biology, but the fact of the matter is using that stage doesn't tell us anything about our ability to interfere with predetermined biology. Biology determines the rate of growth, but our ability to evaluate biology is getting much, much better than it was when we developed TNM staging, and our ability to interfere with that biology is also getting better. And those two factors are incredibly important, and both of those issues kind of negate the fact that we've been using anatomy as our surrogate for disease biology for so many decades. Biology is king. So what else might we measure besides TNM? We might measure immune activation or infiltration or immune evasion, metabolic competition in a microenvironment, clonal response to external pressures. There's all these other things that we could be measuring to figure out biology. And there are some folks who have some experience, some publications in the space of looking at biology instead of TNM. This is another paper from colorectal cancer, again looking at other malignancies taking the lead before us. But these investigators defined 3 subtypes of colorectal liver metastasis through integrative molecular analyses. And molecular subtypes were found to complement clinical risk stratification. After they went into this great effort to basically use molecular markers to identify different subtypes, they found that those with the lowest risk molecularly had substantially better 10-year overall survival than those with highest risk. And here they questioned whether in these patients with oligometastatic disease, does it really matter that they were stage 4, or is this a molecular subtype that makes much more of a difference? So here we can look at biology instead of TNM, but then what about not only measuring biology, but also changing biology? This was a paper published in Red Journal in 2019 using patients from the data set from the landmark oligometastatic trial published with Dan Gomez as the first author from 2016. Many of you are familiar with that Lancet Oncology paper. But peripheral blood from patients who received local consolidative therapy in that oligometastatic trial were evaluated at baseline, early follow-up, and late follow-up. Important findings were that the baseline IL-1 alpha was associated with both OS and PFS. And for patients who had local consolidative therapy compared to maintenance therapy or observation, it was associated with decreased ctDNA burden in terms of fewer mutations and decreased variable allele frequency, as well as oligoclonal T-cell expansion detected at early follow-up. So we can not only measure these aspects of biology, but there are ways that we can change it through some of our interventions. So again, biology is king. We have all these other things that we can measure, but we also can measure biology's response to our interferences. So how can we interfere with biology? I'm going to argue that we can change the biology through local therapy, oligoclonal T-cell expansion with LCT, as I just mentioned, but also through outstanding systemic therapy. We have better and better drugs, targeted drugs, checkpoint inhibitors, ADCs, biospecific antibodies. We have all these different ways that we can change the biology of the disease. So how do we measure the changing of the biology? This is just one timeline that we've proposed. This was something that I published with Carl Gay earlier this year, looking at timeline of operating in stage 4 disease for patients with oncogene-driven stage 4 lung cancer. And you can see that in this pathway that we propose, we're measuring the patient's biology. We're not saying how many metastases did they have an effusion, are they M1A, M1B? We're not really obsessing over that. We're taking any and all comers with aggressive, anatomically extensive stage 4 disease and saying, but how are they responding? How are we changing their biology with a targeted therapy to make them behave more like someone who's early stage disease? And when all the metastases disappear, does stage really even matter? That's what we're trying to answer here. And so we're assessing at all these various time points and ultimately treating many of these patients as early stage patients when we have changed their biology with systemic therapy. So the changing biology with surgery, I think there's a lot of rationale in polymetastatic disease to get rid of the primary source for subsequent metastases, to minimize the tumor cells that are able to develop mechanisms resistance, getting rid of those persister cells, debulking to leave lesser disease burden for effective drugs, and hopefully converting a lethal disease to a chronic disease. In OMD, we talked a little bit about comprehensive LCT to get rid of all the disease, but also when we think about surgery, potentially over other modalities, recognizing that we do all need to get along and patients may need multiple different modalities over the course of a chronic disease, we do get a lot of information from surgery. We get tissue for updated pathologic response, mutational analyses. We also recognize that many of the persister cells that can evade targeted therapies may also be left behind after radiation. And then, of course, we always want to think about quality of life and patient and family preferences. So, in summary, I think the question is, what matters? Ultimately, as we think about the fact that biology is king, and it's the patient's response to disease that may matter much more than their anatomic extent of disease at the time of presentation, I would argue that improved systemic control is incredibly important. And then within that circle, we'd like to provide optimal local control. And that stage, perhaps, is irrelevant. So to answer your question that you've posed to me, Dr. Spicer, when metastases disappear, is stage meaningless in the face of biologically tailored systemic therapy? I would argue yes. Thank you so much.